All right, we're live.
Okay, thank you. We're back. We're moving into the healthcare flexibility, regulatory flexibility bill that we have been working on as a committee. And the House has put together some language on audio only. We've found how critically important telemedicine has been during the pandemic, and an interest in continuing some of the practices, including audio only. But it's my understanding that we're also interested in having appropriate guardrails going forward so that we're not allowing every single phone call, but at the same time, we want to ensure patient safety and patient access. And we've heard that patient access is pretty critical. So the way I want to organize this is to have, disregarding the order on the agenda, because everyone has sort of called in and asked to testify. I'd like to hear from the insurance companies first, and then we'll move on through the list after that. So, and I understand, Margaret, that you are here. Charles Storrow is here, and Dr. Kate McIntosh is here at Sarah Teachout's request. So let us, I don't know, and here's my other, my really important request is, as each person is testifying, whether you're representing an insurance organization or other, or yourself, if you hear something that you were going to say, please just let's not have a lot of repetitious testimony. It's more important that we have targeted, independent, novel testimony from each person. That I greatly appreciate that. So, Margaret, thank you for being here.
All right, thank you for having me. My name is Margaret Lagus, and I'm representing America's Health Insurance Plans, which is a national association of health insurers. And we really appreciate the opportunity to chat with you about the audio-only provision. We understand that during COVID-19, it was really necessary to allow providers to not have to deal with new codes and still be allowed to offer audio-only options to their patients who couldn't or didn't want to come into the office for safety reasons. And as I believe Sarah Teachout testified, or Blue Cross did, there was literally like a hockey stick increase in the use of telemedicine or telehealth overall during COVID. It was a dramatic increase. There was no way for doctors to have prepared for that, for the offices to have prepared for that. So we understand why the payment parity issue started out and remains during the pandemic. We do believe that going forward, we should use data first and policy second. So we should be collecting data once the pandemic is over on the use of telehealth and what reimbursement rates should or should not be, versus setting the rate and then finding out 3 years from now whether or not we did the right thing. Change is happening incredibly rapidly in this era, as we all know, with everything that's involved with the internet or anything. Change is happening really rapidly. There are a tremendous number of new companies that are coming on that are offering telehealth. They're offering it for as cheaply as $15 a visit. Teladoc standard rate, I believe, is $50 a visit. I think that my copay, I have a high deductible health plan. My copay, not a copay, my payment for a doctor's visit, a primary care visit, is $125. So that would be a big savings to me if I could pay $50 to telehealth versus seeing my primary care doctor. And I think Vermont does not want to freeze Vermonters out from some of these savings by arbitrarily saying that the payment to the doctors has to be the same for an in-person visit. I think that doctors do have time to change up their practices. They could see potentially more patients, not have to expand their waiting rooms or have the nurse intake staff or the folks that check you in at the door. There are a lot of savings that could be garnered here. I sent you all a study that talked about the fact that telehealth can save money on a per visit basis, but one of the things that happens when you use telehealth, as you all have known or have seen, is that the convenience factor means that many folks might actually seek care that they otherwise wouldn't seek, even necessary care. For instance, folks that can't take a day off from work or don't have transportation or don't have affordable childcare. can't get into their doctor, but they could pick up the phone and could take a 15 or 20-minute break at work and call their doctor and get care. So there might be an increase in use. And so it would be really detrimental to Vermonters' overall price of health coverage if we kept the payment parity and then saw this increase in use of telehealth that then would send the rates upward. So we want you to think about those things, and that's why data should come first and policy should come second, especially because many Vermonters do have high deductible health plans. And the difference in care, like I said, I could find a $15 online appointment just 2 seconds on my computer. So many Vermonters could do that. And we really don't want to break that tie between somebody's primary care doctor and the patient just for the sake of saving $100. But $100 is for many families more than a week's worth of groceries or 3 tanks full of gas. It's really the difference between, making your budget and not making your budget. And if you have a high deductible health plan, you're paying for almost all of your care probably out of your pocket on top of your premium, because you're never going to meet that family plan deductible, which at least for me is $12,000 a year. So I think that the downsides to telehealth, where you might not want to increase its use, are that there are some privacy considerations. And I don't mean privacy as in you're using an internet connection. I mean, as in, for instance, a friend of mine was having a telehealth conversation with her doctor the other day and her husband walked in on her. Well, who knows whether that was a domestic violence situation. She could have really gotten in trouble for that. So those things, you're not in a private room with your doctor. So the care is really different. You're not collecting a set of vitals. So you're not getting that care. You're also not having that very private conversation with your doctor that you can have only if you go into the office. And so for those reasons, we really would like you to consider collecting data for a while and then setting the payment rate. And so in the interim, once the pandemic is over, that the rate setting should be between the insurer and the providers. And that I'm sure that there will be a whole new bundling of this, because telehealth is not going away. And so I think that insurers will recognize that it's just going to be a part of the continuum of care. But we really don't want to break that connection between a primary care provider and their patient by having Vermont's payment for a primary care visit be $125 for a telehealth visit versus $50 or $15 for a teledoc or some other online visit. That'll ruin your electronic medical records. You won't have as broad data on that individual patient, and that care might not ever get into their health record.
Okay. Is that it, Margaret?
That's it.
All right, thank you. I guess what I do want to ask a question, but I want to make sure that we have sufficient time for everyone on our list. I'm going to ask the questions, and then I will continue on, and maybe these questions will be answered as we go forward. But the question I have is then, you're making the assumption that within the audio only language that a first visit would be allowed by telephone only. So that I'm trying to infer what you're saying, that
it doesn't have to be a first visit, any visit.
Oh, okay. So any visit would cause for a patient to leave their current practitioner.
So what I'm saying is that if I call my doctor and say, I want to do this over telehealth, in this language, it says they would have to let me know that I'm going to be paying X number of dollars, whatever that primary care visit is on my health insurance plan. For me, that's $125. So I'm saying if I know that and I'm a lower income Vermonter, I might well go online and choose to use a $15 service or a $50 service offered by some company that's offering telehealth online. Okay, so we'll have to look at the language with that in mind. That's helpful. Thank you. Okay, and then the issue there I also see is, would that telephone call meeting appointment be medically appropriate? So there's a lot embedded in that decision making. Okay, thank you. That's good. All right, and I'm gonna move ahead, Senator Hardy.
Well, can I just ask
a question of clarification?
It's not a question for Margaret. It's actually a question for Jennifer Carby. I just tried to message her about where the language is so I could take a look at it as I'm listening to the testimony. Is it in the larger draft or is it still separate?
It's still separate, and I can work with Nellie to get it posted as soon as possible.
Okay,
Good
great. Thank
question,
you.
Senator. Thank you. Thank you. Good question. All right. So thank you. And we are going to move on to Dr. McIntosh is here. Where is she? There you are. Welcome again. It's good to see you. And thank you for being here. So we'll listen to your testimony.
Good morning, Chair Lyons and members of the Senate Health and Welfare Committee. Thank you. So my name is Kate McIntosh. Some of you know me, some of you don't. I'm a pediatrician. I've got 22 years of practice experience, and I ran Rainbow Pediatrics in Middlebury, which is an independent practice, for 16 years, and I'm now the Director of Quality at Blue Cross. So when I come to audio only, my experience as a pediatrician and my work in quality at Blue Cross shaped my perspective on audio only care. And my primary concern is really for patient safety. And while I really appreciate the patient protections that are in this legislation, I'm asking you to give careful consideration to the limits of the telephone. So we support expanding the use of the telephone to supplement healthcare. But in this post-pandemic world, we want to make sure that it takes its proper place in the spectrum of patient care. And we are concerned about promoting it to replace high quality in-person visits, and that the policy of paying it at the same rate as an in-person appointment will do exactly that. Just because we are providing access doesn't mean that telephone care always offers the same quality or the same value. And as a pediatrician, I have extensive experience with talking to patients and to parents on the phone at all hours of the day and night. And it's given me a very detailed understanding of the benefits and of the limits of telephone care. For example, infants, nonverbal or partially verbal children, incapacitated adults who can't speak for themselves or may rely on a different care provider to give a verbal assessment of their condition, compromise my ability as a provider to do an independent assessment in that kind of situation. So when a parent calls me and says my child looks sick, and I have lots of experience with this, I need to visually see that child to know what sick looks like. Sometimes sick means they look like they have a cold, but sometimes sick means they look like they have meningitis. And it's very limited to be able to, you can't do that over the phone. You can't see what's going on over the phone. And that distinguishes the telephone from even audiovisual telemedicine and from an office visit. And I think that it's very important to remember that. My other concern, and the similar concern, is of the steadfast Vermonter. You know, we've had patients who don't grumble or complain, and they may not know how ill they are. And a telephone call may or may not allow a provider to discover this. We're trained as physicians to use all of our senses to get a full understanding of a patient's health, and even to know what follow-up questions to ask. And because audio only lacks the visual input, the tactile input, and the ability to examine the patient, even somebody like that stalwart Vermonter or anybody else whose perception of their condition might not have the whole story is very concerning, because I might even not be able to tell what questions to ask in follow-up. What pertinent questions do I need to be able to use my other senses to be able to formulate, to ask the person, to know if the story makes sense? And this is why I really strongly feel that audio-only care doesn't have the same value as in-person care. And crucially, because this proposal asks us to pay for those telephone calls, you're going to be asking for the value of a service delivered to be less for the same cost. And that will increase the cost to the system. Also, we're going to see more follow-up in-person visits after a telephone call because of the automatic limitations of the telephone call. And then finally, I think we may see increased cost due to these either recognized or unrecognized limitations of telephone care, because they can result in an incomplete picture. They also can result in misdiagnosis and overprescribing. So by allowing us to negotiate these rates, we will be able to preserve the access that you want, but we won't incentivize lower quality care. And all of these concerns are amplified with a new patient. right? Because now there's no baseline relationship between the patient and the provider. And when I have a new patient, I have to be able to establish this baseline. And without all of those inputs that we're talking about, it's very difficult for me to do an evaluation on someone because I'm limited only to what I hear. And so we are strongly urging you to remove the new patient section because we don't feel like first visits by telephone, by and large, are a good idea. And so there may be areas where they're appropriate, but those should be determined by medical policy, not by, not by across the board. And finally,
Can I ask
right.
you this question about that?
Yeah.
Well, no, finish up because it sounds like you're getting to finally.
I just have one more point. Yeah.
Yeah,
So
go
there
ahead.
were questions in previous sessions about the check-in. Will the check-in be billed? The check-in, which is so often used by pediatricians, but also
Yes.
to follow up lab results or to follow up radiology results. Prior to the pandemic, these check-in calls were not paid separately. They were billed as part of the office visit. The code was automatically added into the code for the office visit. During the pandemic, those codes have been turned on and they are in this bill to be turned on long term. So to answer the question from last minute, Senator Hardy, I think this was your question. Yes, that follow-up mammogram will generate a charge. So will the call to the pediatrician in the middle of the night. And they might be check-in charges or they might be full-on visit charges. And so these are going to be new charges for patients and they may make people hesitant to call their providers. But both types of call are going to increase the cost in the system, both in terms of patient burden and in terms of rates. So anyway, I will stop there, but I do think there is a place in the healthcare spectrum for telephone, but it has to be placed appropriately for cost, quality, and for value.
Okay, thank you. And I think it will be helpful if you have suggestions for improvement of the language, and I've heard a couple already. The one concern about a new patient, I think we've expressed in this committee. My question about new patient, and I've also heard from folks, I'm sorry, that not what I need right now. So it's my phone ringing, I apologize. We have heard that a mental health first visit might serve a purpose by telephone, particularly with youth. And we've also heard that youth telephonic connection it will be very effective just because some adolescents are less less resistant. So if there are ways that we could modify the language that would allow for us to go forward to collect telephonic data over the next 18 months or 18 months after the end, your input would be very helpful. So just in
Yeah. And I don't disagree with you about certain types of mental health. I think that this may be an arena where medical policy needs to can govern the value of care, because I think that you're right. I think that there are dangers to first-time visits with mental health, but there are also potentially real benefits with first-time mental health. There's clearly, the teenager who won't talk to you in your office, but who will curl up on their couch and spill their guts to you over the phone. That there is a real positive there, but there are major negatives as well. So I think that it's a complicated, nuanced area of care. And to blanket it as being equally valuable across the board for all office visits, rather than letting it become a kind of negotiated and policy-driven, evidence-based driven process, risks creating a real kind of quagmire, both financially and also in terms of safety and quality. So I do agree with you that there are definitely places where we are seeing that it's effective, but there are also places where we have real concerns.
So I guess one last request would be, I don't see any testimony from you, but it would be extremely helpful if you, within Blue Cross and Blue Shield, could provide us with some perhaps language improvements or some of the areas that you see would help us move forward with this section of the bill.
Absolutely. And I think
Okay.
it's important to differentiate telephone from audio visual because they
Oh,
truly are
we're-
different.
I think you're preaching to the choir.
Sorry.
Thank you. Senator Hardy.
Thank you, Madam Chair, and thank you, Dr. McIntosh. I know you're here representing a health insurance company, but as you obviously know, I know you as a doctor, including a doctor who's taking care of my own kids. So I actually want to ask you from the perspective of a medical provider, which of course you are, the question about, I'm looking at the language. Thank you, Jen, for getting it to me. We have in there, or the House included language that says medically necessary and clinically appropriate healthcare, so that, physicians wouldn't be required to provide audio only care for patients if they didn't think it was clinically appropriate. And clearly, as a pediatrician seeing an infant, it would likely not be clinically appropriate to test over the phone because they're nonverbal. So does that provide enough protection, that language, or would you like to see additional language that would guide physicians about when they can and should say yes to an audio or can and should say no to an audio appointment? That's my first question. And I also just in the interest of time, want to reiterate, underscore what the chair did about language about the first visit. We had talked about mental health as a potential exception. The timeline, I'm interested in your thoughts on the timeline. This extends it out to, I think, 2024. And you yourself said the collection of data is really important. So we're trying to embed some kind of timeline for collection of data, and also language that would potentially get to that point that you made about the follow-up calls and not billing for those as those being part of the original visit. And so what language would be necessary for that? So sorry to say so much at the same time, but trying to be efficient.
That's terrific. And I think those are the questions that we would like to perhaps have you respond to. And if you can do that and get some information to Nellie, that would be very helpful. We'll ask.
Could she answer the question though about the clinically appropriate at this time, or share a few thoughts that
we can? I'm looking at about 8 other people to testify, so you can ask that question. Go ahead.
It's a really good question. And I think that the challenge is that it would be nice to be able to say, yes, we can simply say that is what happens. But the reality is that with telephone only, and I'm talking about telephone, not audiovisual right now, there's no state, and in fact, as far as I can tell, no country has ever done what we're talking about doing here. We're really far out ahead of research, ahead of best practice, ahead of standards, ahead of anything. So what you're doing is relying on every single individual physician and every single individual provider to make a personal decision about what they think is appropriate. And as the chair of the credentialing committee, I can tell you there are a wide variety of providers out there. So when I'm confronted with something like this at Blue Cross, I govern it by medical policy, and I put evidence-based standards in place as medical policy about what is appropriate in this situation. And our telephone policy contains this kind of language. Whether it belongs in a bill in the Senate, I just don't know. That's where I get a little bit stuck. But I'm happy to give you as much follow-up language as I can with regard to what we're trying to do to create these evidence-based guidelines.
All right, thank you. Senator Cummings. You're muted, Senator. After all this practice.
I know. I'm trying to get to the heart of the issue. Everyone wants to make sure that we extend access to healthcare. But it sounds like, audio telemedicine is new. Audio only is a brand new field. And we have, by saying it's charged at the same rate as an office visit, is cause for concern. And I'm trying to figure out, what are you at? I've heard the word negotiate. Are you asking the insurance companies as they go through, the ability to negotiate in their policies what they will pay for an audio-only call, so that we don't end up with the, geez, I can go to ZocDocs or Teledocs online and pay $5 or $10 or $20. And if I call my primary care provider, I'm going to get hit with double that or triple that. Is that what we're trying to keep some flexibility in this?
What we're trying to be able to do is to keep flexibility to align the triangles of quality and cost so that you end up with a high value service. And that high value service then has its appropriate place in care. So there's a lot of data on, for example, audio only to do things like care coordination, follow up, smoking cessation, those kinds of things. But this idea that a telephone can be used for an office visit is brand new and not verified and not supported by evidence and research. The British are the farthest out ahead on this from the research that I found. And what they say is it's a good concept, we should explore it. But there's nothing out there. And we don't have to, we can collect data without paying at par. I mean, so we can collect data without paying at par and look at things like hospitalizations, follow-up visits, overall acuity, emergency room visits, things like that. As this runs out, there is a role for the telephone, but it's not clear what that role is from a quality standpoint. And that's why medical policy would govern. I mean, we would say, you can do this, but you can't do that. I mean, for example, you can't do a surgical follow-up over the telephone, or you can't do a 9-month well child over the telephone because you can neither see nor hear the child. So you're not really doing a well child check, right?
So I think
Right.
we
I know
get
you're-
that. These are the things that we've heard, and we have heard that there were guardrails in place to protect that from happening. So if you have suggestions that would improve the language to ensure that some of that's in there, that would be extremely helpful. Senator, if it's a short question.
It's a really short one. I think what I may be hearing is that because this is so new, you really don't have a standardized what is clinically appropriate. So that guardrail doesn't guard. Is that
Correct.
what I'm?
That's why we need data. So it is called, for me, catch-22. So we're trying to figure out the best way to do this. So we collect the data, we have the guardrails, and the patient is protected. It's just fun. It's a fun one.
To your point, there are training programs for physicians on how to use audiovisual telemedicine in order to give better care. That we haven't even gotten there with telephone.
Well, we're going to get there. I think if any state can do it, you can do it, Dr. McIntosh. Seriously, I mean that. I want to move along, and Charles, I know you're here. I know that there are people with us who are not ordinarily with us and may have, is there anyone who's here ready to testify who has would have difficulty getting back into one of our meetings another day and making Charles, I'm hoping that you would say you could hold off for a couple minutes.
I'm totally flexible, Madam Chair.
Thank you. And I see Faye Holman's hand is up and Teresa Fama's hand is up. So why don't we go directly to you? And I think, Teresa, you're first on the list. Dr. Fama, thank you for being here.
Thank you. My name is Teresa Fama, and I'm a rheumatologist at Central Vermont Medical Center, and I've been there for 14 years. I'm also the regional physician leader at CVMC and a medical director for specialty care services there as well. I have a background in health policy. In these roles, I have significant knowledge of the state of e-health, also known as telehealth or telemedicine at CVMC, and I thank you for the opportunity to share my views. One of the few benefits, very few benefits of the COVID pandemic, was to push us to develop ways for our patients to continue to receive care during the pandemic. This was done initially via phone visits, and now much more commonly with video visits, as this capability was rapidly expanded in our network. This has allowed us to continue to see our patients despite the challenges and safety concerns. From my experience in my own practice and in the administrative roles I have at CVMC, the type of visit, whether it's in-person, video, or phone, is determined mainly by the clinical scenario, as well as the patient's circumstance and their comfort level with coming to the office. Based on the data from CVMC and the other community practice division hospitals in the network, phone visits were more common during early COVID days. But once we were able to initiate more widespread video capability, video has surpassed phone visits by far. In-person visits remain the mainstay, comprising at least 75% of all visits. Less than 25% of visits are telehealth, that is video plus phone. And this has been consistent over the past several months. Only a minority of all clinical visits, roughly 5 to 7%, are by phone only, or audio only. And so thus, this does not constitute a massive utilization of telemedicine, even during a pandemic. It's imperative that we continue to have access to audio-only visits for the following reasons. One, Vermont's broadband capabilities are poor at baseline. Video conferencing is not possible in some areas of Vermont, and I see that challenge almost every day. Older adults tend to have less access to or capability of using video conferencing. And as we know, close to 20% of Vermont's population is greater than 65 years old. Patients often begin a visit as Zoom or a video technology, but then due to Wi-Fi or internet issues, we need to abort the visit, or sometimes the visit doesn't even start as intended. Because we can convert these visits directly to phone right there on the spot, we don't have to reschedule them to an in-person visit, which some patients don't want to do. And for certain specialties, such as mine in rheumatology, it would mean if I had to abort that visit and I can't turn over to phone, that means that patient may not be able to see me for at least another 3 months because of access issues with my schedule being booked out so far, as we see with some specialties. So having that ability is pretty key. Another consideration is that Vermont's healthcare environment still is predominantly fee-for-service and not value-based. My colleagues and I, we phone patients informally to discuss test results, to answer questions, and to triage patient symptoms. These phone calls often happen on our own time, during our lunch hour, after hours, on the weekends, during the evenings. This practice has remained mostly unchanged, despite having phone or video option with patients for initiated calls. However, knowing that we have the option potentially of creating a formal visit not only allows us not only to get credit for the visit, because our compensation is still widely RVU based, but formal visits over informal phone conversations result in improved documentation, since the visit is now scheduled rather than informal, as well as improved morale for providers, since these visits happen during clinical hours and not during non-clinical hours. Regarding co-pays for these visits, I have yet to hear any complaints from any of my patients or patients in our local medical group that this is an issue. In terms of the types of visits done via phone visits, as a rheumatologist, my clinical expertise often rests on the management of pain in my patients. I have not yet once encountered a request for a phone visit to accommodate narcotic prescribing, not once. Regarding established visits versus new patient visits, some specialties, including rheumatology, rely predominantly on in-person visits, with video being an option for some new patients. I rarely use phone visits for new patients, given the nature of my specialty with needing to do a thorough joint and physical exam. However, for some specialties, such as psychiatry, I can understand that phone visits might be an acceptable option for new patients. Finally, as we spend our first full winter with having video and phone visits for options for patients, with the last 2 snowstorms, I was able to convert patients from in-person to video or phone, again, depending on their clinical scenario and their preference and their ability, the day prior to the storm. For patients who did not have access to video, this meant that they could still receive care on the day of their originally scheduled appointment. Otherwise, as I mentioned earlier, I would have had to, their care was going to potentially be delayed by about 3 months because of my book schedule, which is unfortunately true for several other specialties in our state. Hearing patients express their thanks to me for this option, resulting in them not having to drive in bad weather or reschedule the appointment, was clearly the highlight of my day on both days that I did that. And I don't understand why we would ever want to go back to what we used to do, given the expansion and access and improved patient satisfaction. Thank you.
Thank you. That was clear, comprehensive, and you had some data to support your statements. We appreciate that. I'm going to move right through the doctors who are here because I think they raised their hands early on about having a time crunch. So we'll move to Dr. Faye Holman, and then we'll go to Joe. Is it Lasik or LASIK? I would.
LASIK.
Okay, thank you. Dr. Holman, thank you for being here.
Thank you. Thank you for having me. I'm Faye Holman, a family physician in a town of 450 Wells River. I also serve on the Vermont Academy of Family Physicians Board and the Primary Care Advisory Group. And so I have a lot of contact with primary care providers across the state regularly. Many of us in rural medicine have been surprised at the effectiveness of providing healthcare by telephone. When the circumstances are carefully selected, the phone-only visit can improve access, safety, and importantly, equity in healthcare, especially when done in the setting of a medical home in patients where we already have a relationship and we know them. I'm just going to tell a couple of quick stories about phone-only visits. One is about a healthy senior and one is about a sick baby. I recently did a phone visit with a 95-year-old who had been in the hospital for congestive heart failure. She was on a great number of medications, many of which have been adjusted in the hospital. She's a super senior, and over the phone, she was able to give me pulse and blood pressure readings from her home monitor, the daily weights that she had been taking, which we monitor for fluid retention. And we were able to discuss side effects to the meds. And even somewhat of a physical exam took place because with her super chatty and long sentences, I was able to assess her mood and whether she was short of breath or not. It was a real visit in every way. Here are some of the things we avoided by having her do her visit over the phone. Her family members did not have to take time off work to bring her. She avoided leaving her house and walking across her driveway and our parking lot on an icy day. And she avoided sitting in our waiting room with the possibility of exposure to things like COVID, flu, and other viruses. I don't have to tell you what the obstacles to a telehealth visit would have been in rural Vermont with a 95-year-old. But when I mentioned equity, that is one of the things I think is important to keep in mind here. If we have embraced telehealth visits, not embracing phone-only visits is an issue for health equity for much of rural Vermont. And it's not just their internet connections. At my office, we don't reliably have enough bandwidth to support telehealth visits. I'll tell a quick story about a sick baby as well. And this occurred with a colleague of mine, not in my own office. She did a phone visit with a family with a 1-year-old who wasn't feeling well, breathing fast, drinking a lot, but not eating well. Over the phone, she was able to, and the family was not willing to come into the office because of isolation from COVID. Over the phone, she was able to talk the family through, lift up his shirt, tell me if there's a rash, watch how he breathes. Do you see his belly muscles moving when he breathes? And over the phone was able to diagnose this 1-year-old with new onset juvenile diabetes. This is a medical emergency, can be fatal with electrolyte abnormalities and dehydration. And because of her relationship with the family, was able to convince them that this was a time when they should leave their home and go to the hospital. Subsequently, she called the local hospital to tee up the labs and the IV fluids to be ready for this baby, and talked to Dartmouth, where the baby was subsequently admitted to the pediatric intensive care unit. In this phone call, she did a diagnosis, a physical exam, although verbal, was able to convince parents to get care for the baby because of her relationship with them, and coordinated care with 2 hospitals. How is that not a reimbursable visit? There are many things in pediatrics, especially, that work actually quite well on the phone. A lot of what we do with our parents are questions about child behavior, child development, parenting strategies. Phone is never a replacement for physical exam and in-person relationship, but for many of the things we do in pediatrics, it is a very good adjunct. There are other things we have found work well as phone only. For instance, our MAP patients. We have one now who is doing well, has a job about an hour from where we are. For him to come and make his appointments, he has to take time off work where he's trying to prove that he's a reliable worker. And being able to do his very frequent MAP visits every 2 weeks usually by phone has made a world of difference in his work life. And there certainly wouldn't be any opportunity for him to do a telehealth visit at a construction site. There's been some mention about whether new patients are suitable for phone only. I think it's certainly not ideal and shouldn't be considered something that was standardly done. But I can think of 2 situations where it might be very valuable. One was told to me by a colleague who practices in Stowe, and a family had moved from out of state during the pandemic and then developed COVID. So they needed healthcare, they needed coaching about what to look for and when to seek care, but really did not want to be brought into the office for that unless there were significant signs that made taking that risk to other patients worthwhile. Another situation is when I get a request for a new patient, there's a process, we get records from prior physicians, those records have to be uploaded and put into REHR. But often people make that reaching out for a new provider when they're having an acute problem. They're having severe back pain, they're having severe depression, shortness of breath. Being able to give them an acute visit over the phone or by telehealth, but in our area, much of the time that's phone only is what's available. Allows them to avoid an emergency room often while teeing things up to get into primary care. So audio only with doctors who don't know you, will never know you, and don't have any records about you or any plan to follow up with you, terrible idea. but in the context of a medical home, it can make a big difference in getting people the care they need in the time and the place that they need it.
How close are we?
I'm done.
Dr.
I was just going to thank you for thank you for listening. I have some secondhand experience with the long hours that you work and the difficult decisions that you have to make. And thank you for listening today. Just keep in mind that the people that we would be excluding by excluding audio only are often rural, elderly, and seniors. Thank you.
Thank you. And if you have testimony you can send to Nellie, that would be helpful. At this point, we're getting very close to our end games, and I'm going to ask if the VPQHC folks and Chuck Starrow might be able to join us tomorrow or Friday, and Nellie can arrange that if it's possible. Thank you.
Absolutely, Senator Lyons.
Thank you very much, Catherine. I appreciate it.
No
So,
problem.
Thank you. Dr. Lassick is here, and I know that Lynn Stanley said her testimony is quite short. So let's see if we can hear from both folks. And Senator Cummings is going to tell me she has a meeting at 12.
You got it.
That I think we'll listen, and then it'll be short enough to Zoom go to YouTube and look at Senator. So we'll stick with it at least for a little bit after 12, but not too much after 12. So Dr. Lassick, thank you for being here.
Thank you, Senator Lyons. And I have submitted my written comments to Nellie, so I'll try to go through this and not necessarily cover every item. Just to introduce myself, my name again is Joe Lassick. I'm a community psychiatrist based here in Vermont for my entire career. Worked at Howard Center in Burlington for 15 years. Recently joined Counseling Services of Addison County in Middlebury, where I was appointed medical director in January. Also work with several other programs in the state, including the Vermont Practitioner Health Program, the Vermont Psychiatric Association, and Vermont Care Partners. My message today is pretty straightforward. All healthcare professionals have been providing telephone-based care for as long as there's been telephones. And as part of our training, our basic training and ongoing experience, we all learn how to use telephone-based practice as an integral part of our practice every single day over the course of our careers. What we learn to do is to triage each case, each situation. When we take a telephone call, often it happens in an urgent situation, or like Dr. Fama was saying, after hours, calls build up during the day. You make your telephone calls. You're not going to ask patients to come in for every, quick phone call, or even sometimes extended calls, because you have to deal with it that day. The issue is that we've been doing this without any reimbursement. And so I think there have been some really negative effects of that. It forces us to do a great deal, because we are largely still a fee for service. We do a lot of unpaid work. That's put a lot of financial pressure on medical practices and push burnout. Particular concern of mine, as in my role as Vermont Practitioner Health Programs medical director, is burnout in our field, and we've seen that skyrocket over the last 30 years, and then COVID has only pushed that even higher. But non-reimbursed care, non-scheduled care, like Dr. Fama was talking about, really has become one of the chief sources of burnout in our field. I want to also point out that certain specialties are particularly disadvantaged by this. Those of us who do a lot of interpersonal work with our patients, primary care doctors, pediatricians, psychiatrists, this is a lot of what we've always done. And it has, because it is unreimbursed in most cases, it makes these specialties relatively disadvantaged compared to other specialties who can charge for procedures that are reimbursed. And so we have seen a marked decrease in interest in these specialties, and I think this is one reason that's the case. But most importantly, I would say that what this has done is decreased access. The fact that we often cannot bill for this care drives patients, drives us to schedule patients sometimes when that isn't necessary for relatively straightforward assessments and evaluations. We could do this by telephone, but because we can't bill for this care, we often will then say, well, instead come in a couple weeks and have the in-person appointment. I've also heard some concerns about quality of care, especially, well, in two ways. One is, is this the same level? Can you actually do this work at the same level of quality? And in psychiatry and psychotherapy, there's actually a pretty well-established literature, and I've included that link in my comments to review, including a recent systematic review showing pretty similar outcomes with telephone-based care. I would also say that over the last year, all of us have gotten more experience in knowing how to do this effectively, knowing when it's appropriate to get off the telephone, bring people in for in-person appointments, or really to focus on getting that video access when we can possibly. So we all have gotten better at this as the years gone by. Talking about specific situations where I found telephone-based care to be extremely helpful, even in cases where I had not thought about it previously. In psychiatry, we work with a lot of folks who have significant depression, significant agoraphobia, and I've worked with now numerous patients this year who had dropped out of treatment previously or weren't willing to access treatment because they were too afraid to come out of their homes or unable to do so. And I've been able to engage them through telephone-based care when video was not accessible to them. I work now in a very rural county, so geographical barriers are a real issue for us. Other folks have mentioned issues around health equity, and that is the case. It's older folks, poorer folks who can't or don't have access to the access to transportation. They have benefited greatly from having telephone-based access. I have heard some concerns about offering telephone appointments for initial evaluations. And what I would say about that is, ideally I want to meet with a patient via video at least during my first appointments. That it is important to get that visual data, ideally in-person contact. But there are definitely situations where having telephone availability has been helpful. And I've mentioned already folks who are depressed, folks who are agoraphobic, but other situations include those with significant paranoia. These are often our most concerning patients, people who are have such strong persecutory thinking that they don't feel safe with video access. Those who have had poor experiences in treatment before and who have issues around trust and establishing trust. And it's also been helpful with these folks having the ability to have three-way telephone calls, often with treatment providers or family members. One specific case I had just this past Friday was a young woman who was in a hospital discharged against medical advice with no follow-up treatment, and very, very strong anxiety and trust issues, did not want to come into the office, did not trust video access, but we were able to establish a three-way call with her therapist, in which I was able to do an almost complete assessment with her and her therapist present, and establish some basic, therapeutic alliance. And we're going to be working on getting her into either a video relationship or a in-person appointment, but the ability to now establish even a second appointment where we can still work on that engagement has been very helpful. Finally, I would say that telephone-based care has increased productivity. It allows for briefer appointments at times when that's indicated. People don't have to come in. You don't have to do a lot of the small talk that we often do. You don't walk to the waiting room, bring people back, all that sort of thing. It really does allow for increased productivity, often for in cases where briefer follow-ups are indicated. I have several other comments here from colleagues that I've included where they have seen telephone-based care really enhance their practice and a strong desire to continue with this. I'll skip over those. You can read those in my written comments. I just want to thank you for considering this important issue today.
Thank you. And we do have your written comments. It's very comprehensive. And thank you for the link to the research on outcomes related to telephone use. Really appreciate that. So I think we're just going to move right along. And we have your contact information, all of you, so you won't be far away from us. Lynn Stanley is here representing a social work profession. Lynn, thank you for being patient and
you.
providing us with your testimony. And I think we also have your testimony, don't we?
Yes.
Yes, we do. Okay, good. So
So,
why don't you said it was short, so we'll,
and I talk fast.
okay.
So, hello, Madam Chair and members of the Senate Committee. Thank you for hearing my testimony today. My name is Lynn Stanley, and I'm the Interim Executive Director for the National Association of Social Workers, Vermont chapter. I'm also the Executive Director for NASW New Hampshire, and up until a month ago, I had been the interim for Maine. You have my written testimony where I've outlined a number of things that you already know at this point. Phone-only option increases client equity, and clinicians in private or small group practice are small business owners, many of whom depend upon private and public health insurance to be reimbursed for their services, much like our larger health service organizations. The telephone-only option has given our clinicians another tool for the toolbox to best serve our clients. Telehealth and audio only is not easier for the clinician. Clinicians need to draw upon all of their skills to ensure interpersonal connection, accurate assessment and treatment, and client safety. But out of necessity, we know now it can be done and be done well. Clinicians use their professional judgment and best practices to determine whether telephone only is appropriate for their client. For some clients, this is the best option. For others, it is the only option. People who don't have access to reliable internet, people who don't feel comfortable using the technology, people who don't have a computer in a private part of their house, or as you talked about before, maybe the teenager who cannot bear to make eye contact right now while talking about their pain and sadness. Every clinician who uses telehealth uses the telephone as backup if the internet decides to get spotty. If the Zoom call gets dropped, they have a backup. For the clinician to say, oh, I can't call you if the video drops because it's not covered by your insurance would not only be unethical, but immoral, dangerous, and possibly constitute malpractice. This means that those private and small group practitioners and our nonprofit agencies would be ethically and clinically bound to provide services for which they might not be fully reimbursed. Not reimbursing or reimbursing at a lower rate for telehealth or audio only further burdens our already overstressed mental and behavioral healthcare systems. The social workers that I talk to report, and this is backed up, report fewer missed appointments. This means people are getting the services that they need even when there's a snowstorm, the car won't start, their arthritis makes it painful to walk, their feelings of paranoia are particularly intense, they're so depressed they can't get out of bed, or the internet is down. We should be making it easier. We should be making access to healthcare easier for clients, not harder. As I previously stated, it is not easier for the clinician. And people deserve to have their mental, physical, and behavioral healthcare needs met using the tools that are available to them and determined to best meet their needs. I thank you for your time. I'm happy to answer any questions now or in the future.
Thank you. That was quick, and it was also comprehensive and greatly appreciated.
Thank you.
Questions committee, and I see that Dr. Fama is still here, and Dr. Holman is still here, so you can ask questions of them as well, I would think. Go ahead, Senator Hardy.
Thank you. I know everyone's really tired. I know I am. I'll speak for myself. But this was a question I asked of Dr. McIntosh, and I just wanted to throw it out there for all of you about the language that we have in the bill about medically necessary and clinically appropriate, and whether you think that covers the bases and provides a good enough fence around when practitioners might choose to use audio only, or if there's some other language that might be appropriate to include in there. And then also your thoughts on the first visit thing. A couple of you mentioned, I think Dr. Stanley, you just talked about it, the first visits as being appropriate, I believe. But I just wondered if anyone had thoughts on that, whether just mental health or all kinds of visits. Dr. Homan, you actually mentioned it. So those were my two questions. Those are things I'm grappling with. And if you have further thoughts, that'd be helpful.
I'll first of all say I can't be given the honorific of doctor. I'm a licensed independent clinical social worker.
I keep doing that.
No, I tell you what, if I ever get my doctorate, I'm going to make my husband, my kids, everybody call me doctor, but I can't call it right now.
Don't count on it. When I got my doctorate, my students started calling me Ginny. So
yeah. Yeah, there's always a trade-off. But I think I can't speak to physical health, but I know for mental health, for some, it is absolutely the only way that they are going to get first seen is through that phone call. However, I trust in the clinician's judgment. If the phone call isn't cutting it, that they will say, you need to come in, we need to get on telehealth, and these are the reasons why, and how do we make that happen for you? So it's the clinician's call. And as you alluded to before, there's a lot more training that needs to be done. There's so much training that right now that has come out on telehealth, and more needs to come out on audio only. And this becomes the responsibility of the clinicians to make sure that they have the professional development that they need in order to do this, to do it right and continue to do it right.
Dr. Homan or Dr. Fama, any response to Senator Hardy's questions?
Sure. I mean, I think in terms of the medically necessary, clinically appropriate, I think you can see that in our numbers, at CVMC. We don't do a lot of audio only visits because often it's not medically appropriate, medically necessary or clinically appropriate. I think as providers, we've been doing a really good job at triaging these visits so that we, do an in-person visit when we need to do an in-person visit, a video when we need to do video, where we can do video, and phone when we could do phone. I think that we've been doing this for a year. As Dr. Lassick said, this is how we're trained to triage over the phone. And I think that's what we do with these visits. In terms of the new person visit, I had commented about that. It's hard as a rheumatologist to do a new person visit by phone only. I've done it and was able to diagnose someone accurately, doing this. I don't prefer it because I do prefer to be able to see the patient, whether it's in person or on video. I'm not saying that you can't do it. And certainly for some specialties, psychiatry, social work, and others where you're doing a lot of phone conversation or conversation only and not relying as much on a physical exam, I think it's completely appropriate.
Thank you. Dr. Homan, did you want to add anything?
No, I think they covered it nicely.
Perfect. Thank you. Well, thank you all for Senator Hooker.
Just a quick question. Both
Sure.
Dr. Homan and Dr. Fama have said that the audio only is a small part of their interaction with patients. And I'm curious, Ms. Stanley, if you have sort of a percentage of the interactions with your clinicians with their patients that is audio only.
I wish that I could say I don't have it, but I could get it for you. I can look to see, but it depends on, each clinician is different if they're doing psychotherapy, and then you have the organizations and agencies that are providing substance abuse treatment. It's quite varied, but I know that the data is growing, and whatever I can get for you, I'll get for you.
Thank you.
Okay. What I'm going to say is that we're way over our time, And I so very much appreciate everyone taking the time to stick with us. We will come back to this, and I'll have Nellie reach out. It will be either Thursday morning or Friday morning, and it will depend a little bit upon our schedule and your schedule. But I know that Chuck Starrow and Catherine Fulton at least need to be heard, and Hillary Wolfley. So we'll continue on with this and hope we can get to some good place. Thank you. And committee, you're awesome. Thank you. Take care. See you later.
Thank you.
Nellie, we're off of you too.